That was wonderful. Thank you so much. I felt like there was so much more there that we could have heard about, but it's like getting a taste. But anyway, so we're now going to move into our last session where we're going to be talking about some cross-cutting issues that are related to all of what you've just heard. And there are going to be 3 speakers. I'm going to give you a little bit of an overview, and then we're going to, I'm going to invite them all to come up and be on a panel, although one of them will be joining us by phone. That's what Kathleen was just explaining to me. So in listening to the case studies that we've heard today, I'm reminded of the problem that we have with medicine, with the development of new and novel treatments, and the fact that there's often a lot of support, if you may, to develop new and novel treatments. You have support, say, from the National Institutes of Health, which will provide grants for doing kind of exploratory research, fundamental research, the understanding of causation of disease and specific approaches to treating diseases. You also have in companies often R&D and a lot of support for troving through various alternatives for finding new therapies. But what we have as a major problem in medical practice is when we even find new therapies, it's not easy to scale them up. It's not easy to spread them among different practitioners. This has wound up being a major challenge, I think, in medicine and in improving the quality of medical care and in bringing evidence-based medicine to the fore in terms of how we perform as doctors. So I'm thinking that there's a parallel here with communities that likewise, that I think today we've heard about several approaches that are very exciting, very novel, very new approaches that have received quite a lot of support from many funders, whether from HUD because of the disaster that hit the Connecticut, New York, and New Jersey coastline. In the case of Detroit, I think we heard about a lot of foundation support that has come together to help to develop some of the approaches that have been taken, as well as corporate support that's come to the fore from the Ford Medical people. And Washington, D.C. also, from a lot of the city leadership, I think government grants, other grants that D.C. has managed to stitch together almost, in my hearing, a bewildering crazy quilt of different grants and programs that they've managed to stitch together to do a sustainable DC process. But, you know, in thinking about this last session, one of the things that I would like us to think about is how do we both scale up and spread some of these practices to other communities? And it's very difficult to do this in the context of medicine, but I'm thinking when you're talking about communities, it's even a more complicated problem, right? Because, I mean, we're trying in medical care as part of improving the quality of care to take into approaches that are much more personalized, much more individual, much more engaging of patients as well as practitioners, much more inclusive of many decision makers in the process. But when we're talking about communities, we're talking about sometimes, you know, thousands, if not millions of people who are going to be impacted, need to be involved. And so that there's that challenge of engagement, because I think one thing that we heard in common between all of these processes is that one way or another there was a tremendous amount of engagement and involvement of the communities. I think there's also the issue of the environment, the context of the environment in which these things are occurring, which are going to be different in different communities, so that different communities may be learning about these things, but wondering, is this applicable in my environment, in my context, or not? there's the issue of the evidence and the foundation behind this, and I think earlier today John Balbus and others raised questions about, well, where are the data that prove the public health benefits from these actions? We have models that indicate there may be financial payoff, public health payoff, but where are the actual data that prove that there's an actual benefit? And then there's the framing and communications, and how does the word get out outside of the region where these efforts are occurring? How do you get the word out to others? And in medicine, we suffer from an assumption that if we have a better practice, that it will just spread, that people will just learn about it and it will just spread. And what we've learned is that that's not true. It doesn't happen that way. And that in fact, there's not an automatic spread of better practices, even if they are much, much better for patients, save a lot of money. Any metric that you can use, they do not spread automatically. And so I'm going to assume that that's true in this instance as well. And I think one thing that we can, think about at a later time after this session in terms of the roundtable is the role of an organization like this, the Institute of Medicine, in helping to scale up and spread these kinds of efforts, whether it's through our own efforts and holding a workshop like this, or perhaps in helping to form what in medicine we call learning communities, bringing people together to learn from each other's experience, whether it's city planners learning from each other, transportation planners, or community groups learning from each other after having these experiences. But how do we identify what the best practices are and share them, I think is a challenge. So with that, I want to move into our session on cross-cutting issues. And I think that two of our speakers are here, and I'm going to ask you to come up. I'm going to introduce you. And then one will be, I think, available on the phone during a certain time window. So we may change the order of the talks depending on how long the other talks take. So we'll just be flexible about that. So I first want to introduce to you Matthew Trowbridge. Physician, associate professor at the University of Virginia School of Medicine, who's been very interested in the impact of the built environment on public health. He studies how health-promoting educational design strategies can support active communities and reduce incidence rates of childhood obesity. He has been a fellow of the U.S. Green Building Council. He has an MD from Emory University School of Medicine and an M.P.H from the Rollins School of Public Health at Emory University. We also have here in person Hazel Edwards. Hi, Hazel. Hazel is an associate of the AIA, has had a 27-year career in research with planning and urban design practice, very focused on issues like quality of life within the frame of the urban design context, and particularly residential and campus environments. She has degrees from Howard University in architecture, Harvard, a Master of Architecture in Urban Design, and the University of Illinois at Urbana-Champaign, the PhD in Regional Planning, and has done postdoctoral work at the University of North Carolina at Chapel Hill. She teaches at the School of Architecture and Planning at the Catholic University of America here in Washington, D.C., and heads their Master of City and Regional Program Planning. Later on the phone, we'll have with us Nicholas Freudenberg. He's a DRPH. He's a distinguished professor of public health at the City University of New York at Hunter College. And he also has been interested in the issue of childhood obesity, maybe not coincidentally, and very involved with looking at municipal policies in cities throughout the world with regard to design of cities and prevention of childhood obesity. He's done some of this work in collaboration with the World Health Organization. And his most recent book is entitled Lethal But Legal: Corporations, Consumption, and Protecting Public Health. And so he will join us by phone later today, and when he's on the line, I can trust that the IOM staff will let us know, and then we'll do that. So I'm going to actually sit here with the two of you.